Global Head of Diversity, Equity, and Inclusion at Eli Lilly and Company, Kelly Copes Anderson. Professor and Chair of the Department of Dermatology at the University of Oklahoma College of Medicine, Dr. Pamela S. Allen.
Thank you so much for joining us today to discuss a topic so important to our community. But to get us grounded for this segment, I would like to start off from a quote from Dr. Martin Luther King. Of all the forms of inequality, injustice in health is the most shocking and inhumane. So let's jump in. There are significant healthcare disparities that exist for people of color, particularly Black people. With the prevalence of healthcare disparities that exist within the present landscape in the United States, many healthcare providers are utilizing a patient-centric approach. Given the many social determinants of health that Black people face, and that includes healthcare access, healthcare coverage, healthcare literacy, employment, education, housing stability, and food security. How do we uplift the lived experience of our patients, giving agency to Black patients and their respective stories?
Ashanda, this is a very, very important conversation to have. You know, I work for an organization that truly believes in the power of diversity, equity, and inclusion. We are committed to DEI, not only to make our organization stronger, more innovative, but more importantly, to make sure that our business outcomes are what we promise them to be. Our goal is to make sure that we can make life better for people all around the world. And that's not just for some people, it is for all people. So this conversation is key to us fulfilling our promise. We've got to make sure that those stories and uplifting the lived experience is part of that. For us, addressing health equity and also recognizing disparities is critical. What we want to make sure of is that we come to the forefront knowing that we have a job to do as a leader in healthcare. And so we've got to be good listeners. We've got to get the insights and understand. We have to have the representation in clinical trials so we have the data, the information to truly make sure that our medicines work in all people.
Thank you so much. Now, Dr. Allen, we got to get you to jump in here. Now, through your work and your research, and also being a renegade in the field of dermatology and having your own skin of color clinic, what has been your experience working with patients of color and their respective life stories and experiences?
Well, just let me tell you, the need is great for Black and brown dermatologists. We are only 3% of all dermatologists in the United States. And we know by 2045 that brown and Black people will become the majority in this US. And so it is important that we have providers that look like our patients, that understand our needs, understand all of the issues that come with our culture, our hair, that others may not understand. And so that is something that we have to change. We have to listen to our patients. We have to understand why maybe they didn't get their medication, as opposed to dismissing them as being non-compliant. Maybe it's because of finances. Maybe it's because of lack of transportation. All of these things can turn into not being able to utilize the medications that a doctor has given to them. And so we have to listen to and understand why a patient may not be able to, their skin hasn't healed. Why from all of this medicine I've given you and it hasn't worked. And so we have to be culturally aware. We have to be culturally humble in the way we as providers ask questions and being able to understand their needs and to fulfill them.
Thank you, Dr. Allen. And so what we're hearing is, how do we connect the intersection of cultural humility, respectful care, but also being active listeners who want to take care of our patients and seeing the value in our patients and their lived experiences. So there are many clinical conditions that manifest differently in Black people. You know, we've already kind of hinted to that, but they appear differently in Black people and people of color. For example, eczema. It may look differently on someone of melanated skin. So what are some ways that this can be addressed?
You know, I think it goes back to when you were talking about the pathways and the importance of really understanding, getting insights, really being good, active listeners, and having that context that while there are many people within the healthcare system, how you show up and what your experiences are can play out very differently. It brings me to a personal story and why this is such an important thing for us to be talking about and addressing, is that my father, he was in and out of the hospital quite a bit last year, having pain. And during that time, the way that he would describe the pain, the doctor wasn't really connecting what was the root cause. And this went on for 2 days. And because of my own involvement and being a part of the healthcare industry for 27 years, I was able to help translate what my dad was saying to the doctor. And the doctor got very frustrated in this conversation. And he's like, well, why didn't he just say what you said? I'm like, because he doesn't actually see it the way that you do. And it was just a moment where I felt it was important for there to be respect, to actually have some patience, to listen, to actually look more broadly at the data so that the best care could be given to my dad. So that is very similar to the work that we're looking to do, even with our Skin of Color initiative at Lilly. It's really around making sure that we diversify the clinical trials, get more data. It's about educating more broadly, not only patients, but also healthcare providers, making sure we have more clinical investigators that are of color so that their own experience can reflect the patients that they're serving. And also the community engagement. How about showing up where people are versus saying, why don't you come to us and we'll help you out? No, we gotta show up. We gotta understand. And we can't come in an invasive way. We need to come in a way where we are a part of the community. And it's helpful when you have leaders and people like myself that are in the company that can show up and be a part of those activations and events.
And we are thankful to leaders like you, so thank you for doing what you do and making sure we are all heard and seen and valued. That is paramount. So eczema is one example of a condition. You know, one of the things I always tell people is that being a person of color, sometimes our hair is our crown, right? So when we lose hair, whether it's from a hairstyle or when we do these protective styles, we want to find security in talking to our doctors about it because it affects us, it impacts us. Even if it's one little small spot, we want to be heard. So, Dr. Allen, what are other conditions that we should be aware of that disproportionately affect Black people and people of color? And how do you work to address and specialize treatment options for patients of color?
So, in my world of dermatology, that is skin, hair, and nails, we see quite a few things that are different and unique in skin of color. Why? Because our pigment cells are very labile. They can get disturbed very easily from inflammation, trauma, all sorts of things. And so you can either get dark spots easier, light spots, and even scarring changes such as keloids. And so these are some of the things that we deal with when it even comes to regard regular acne. Yes, we may utilize the same medications that someone who is of very fair skin, but one extra thing that we have to understand is that dark spot, those pigmented lesions that come with acne, that's important to a patient, and we have to customize treatment when it comes to fading creams and evening out the skin tone. So that is an extra step and understanding that we know why people come in. Scarring alopecias, our hair, as she said, yes, is our crown and glory. And many people do not realize that there is help in investigating why a person of color, especially females, may have hair loss, whether it is scarring alopecias, whether it is traction alopecia from pulling of the hair too tight, or maybe it's hormonal. And so there are many things that I see on a regular basis that can affect a person of color differently than someone else that does not have kinky, coily, curly hair. And so we have to understand that and educate our providers, my residents, medical students coming through, so they are providers for all people.
I think you wanted to jump in there. You
Yeah.
go right ahead. Jump in.
I couldn't help but, if you don't mind me just asking the
Don't
question.
mind.
When you think back to medical school, like, what was the preparation like to deal with all of that difference? I can't help but think about that.
I remember in my medical school days, I had maybe 1 or 2 lectures in dermatology. Did it cover skin of color and the differences that we see in dermatology? No. So there is a push, but it is so lacking in medical school education, in having representation of diseases, same types of common dermatoses that you would see in a fair-skinned patient, such as eczema. But when you see it in a darker skinned patient, there's hyperpigmentation. That's darkness. Many times it's so thick, it can be extremely itchy. And so there are areas that we have to understand and identify with our eyes that this is something that's acute. This is something because the redness does not show up in people of color so much. It's not fire engine red like we see in fair-skinned patients. So we have to understand that redness of inflammation with dark skin looks plum. It looks violet or violaceous. And we have to be able to recognize that and treat it appropriately.
Well, this is, I will tell you, what you're talking about is why we felt compelled as an organization to do our Skin of Color initiative and campaign, is to provide more understanding of how, and provide more understanding of how the disease might play out. Also to make sure that we're educating and bringing more light to the differences that happen. I think that is just so key to make sure that the right care, the best care, as everyone should have an opportunity to live their healthiest lives.
Amen.
It is so important that that is getting done. The other thing that I would say that was it's not only important for now. I go back to something that you said. As we look at what's going on with population growth and change, I mean, over half of our population in the U.S. will be people of color.
Yes.
So it becomes really important that we're inclusive in our care, in our diagnosis, in our treatment, it's going to be more of a opportunity for us.
That's right.
Moving forward.
And just going back, when I was in medical school, again, we didn't get those lectures. We were not seen, we were not heard. And what's important to understand, especially when we talk about black skin, it is not thicker than anyone else's skin. We do not have the ability to withstand pain. We feel pain like everyone else.
Amen.
It is not thick.
Yes.
Okay, always remember that. If you need pain medication, they should provide that for you. That is respectful care. And as we enter this world of talking about DEI, diversity, equity, and inclusion, we always need to understand diversity plus inclusion equals equity. All right? So, getting back to you, we know that people engage differently with healthcare providers. That's real. And I'm hearing that from the audience in their applause. They know this experience. How can shared decision making, which is the process in which a healthcare provider and a patient work together, they work together on their own healthcare decision that is best for the patient. That impact in how can that achieve better outcomes and overall advance healthcare state of a patient?
Such an important question. Let me just say, as in any relationship, it is hard to get the best outcome of any relationship. I don't care if we're talking about marriage or we're talking about friendship or whatever it may be. You have to be able to listen, understand, know what's important, making sure that you then show up in a way that you are actively taking those learnings and then you are behaving and being able to address the things that are of concern and that are relevant. It is no different in the doctor-patient relationship. So when you only have 20% of textbooks that have representation of skin of color, how can you know enough in that relationship to be able to treat well would be my question. And I think that's just an example because I think that's true across a number of disease categories, is that we have to make sure that that our healthcare providers are more informed, that there's more education, there's more representation in data and information available, and that's what's in front of us. That's how we'll be able to get to a stronger relationship. And then we have to value those differences. And I think that becomes really, really important as well.
Thank you for that. I have to always say, all these years I've been a physician, I have the same constant conversation with my mother every single day on my day to work. And what she'll say to me is two things. Put your healing hands on your patients and make sure your patients know that you love them. Patients want to be valued, they want to be respected, and that helps build a bond of trust. Now, Dr. Allen, given the historical examples of medical mistrust, and there are many, okay? There's Henrietta Lacks, there's the Mississippi appendectomy with Mary Lou Hammer, and there's the Tuskegee experiment. I'd love to ask both of you, how can we turn the tide in medical mistrust and work together with our patients to foster trust and arrive at better healthcare outcomes?
Yes, the mistrust runs deep. And I tell you, it's not going to change overnight, but we have to build those bridges. And it was said before, we cannot wait for people to come to the White Castles of the hospital for those relationships to be built. We have to go into the communities and partner with trusted resources. And it may be the faith community with pastors. It can be barbers and braiders and beauticians and estheticians that are on the ground working with everyday people all of the time. And so one of the things that's happening at my University of Oklahoma, and it's not a new thing, is to partner with our barbers and our beauticians and train them as lay scientists so that they, in the chair with their client, can ask, have you got your prostate checked recently, your PSA? What about your colonoscopy? Prostate cancer and colon cancer are high risk in Black Americans, and we die at higher rates, including breast cancer, lung cancer, multiple myeloma. There's so many. And so if there can be conversations had even before you get to a medical facility, as that trusted partner can talk about certain data and things that would benefit you, and to have mobile units at barbers and beauty salons and areas where they can safely and quickly get screenings done. This is one way that we can help the community. And I think there are so many other ways that we can partner with other community organizations that are maybe already doing the work, and we just need to amplify them. And so we've had our own conversation behind the scenes about this and how we will continue this conversation after this segment.
As you talk about the mobile units, that is definitely a way in which we've shown up to not necessarily go into the communities ourselves, but to your point, come alongside organizations that are trusted, who then extend their trust to us and make sure that we're able to help them with some of the great work that they're already doing. Also, it's an opportunity to make sure that we are listening. There's no better way to create trust other than to ask people what they need, and then you show up and return and give it to them. It becomes so important for that exchange to happen. And so then you're in a position to co-create.
That's right.
And you come up with solutions that make sense, okay? You can say the relevant and meaningful solutions, but bottom line is things that make sense. That's what has to happen, those types of solutions. The other thing that I would add is that there's an opportunity, and the focus that we have at Lilly is to make sure that we are creating sustainable solutions. There's nothing more that could lead to distrust is that you start with an initiative and you do it for a year or two, and then you walk away from it.
That's right.
What becomes important is that we invest. This is not a problem. Health disparities is not a problem that happened overnight. This has been an ongoing situation. And with that, it becomes important for us to know it's not going to be solved overnight. It's going to take time. It's going to take investment. And it becomes important that we're there to show up and that we create those long-term trusting relationships. That's the kind of commitment that we have with the community, and we look forward to, through our research, education, and community engagement, to make a difference and create health equity.
So we are hearing about making a difference. We're hearing about commitment. We're hearing about innovations. And what I want to leave this segment is letting everyone know you are important, you are valuable, your health care should be respected, and you should live long enough to take care of your grands, your great-grands, and your great-great-grands. And this is how we do it. We select our healthcare providers. We select those who want to be, we interview the doctors or the providers. You choose them to be on your team, not the other way around. And you want to go into spaces where you're respected but also valued and you are listened to. And that's where we want to leave you. So we have the commitment here from Eli Lilly. We have Dr. Allen, who has created a skin of color dermatologic clinic. That's what we call innovation. That's what we call innovation. And now we're looking forward to community partnerships that are sustainable, that's going to continue those efforts so that we're all healthy and we live to see the great and the great-grands and the great-great-grands and the great-great-grands, and we're going to see all of that. So thank you all for listening to us today, and I empower you all to know that you are valued, your healthcare matters, and you know what you need to do. You pick your doctor yourselves. Thank you, everyone.
Thank you.